All right, everybody got the verbal. It's going to be recorded, and we are ready. A little bit early.
Good morning, everyone. This is Gail Bradley. We will give it just another minute or two until we officially start the meeting. I appreciate everyone participating and calling in so early. Just because we are doing this online, we want to make sure everyone has enough time to get signed and logged in. So we'll just get started probably at 9:02. All right, for those of you who are on the online meeting, can you see our screen okay? You should be seeing the agenda in full screen format.
Yes.
Yes, we can see it.
Excellent. Perfect. And everything okay with our audio? Can you hear us clearly?
Yes.
Yep.
Yes. All right, very good. Well, we will go ahead and call to order. Time is 9:02. Shelley, I will hand it over to you for roll call.
All right, thank you. Andrew Tang. Brent Burgett.
Present.
Chris Salvino. Clifford Jones. David Notrika.
Sorry, present.
Thank you. Debbie Johnston.
Present.
Franco Castro-Marin.
Present.
Gail Bradley.
Present.
Garth Gamer.
Present. Present. Present.
Herman Butler.
Present.
Simon Feiserfon.
Present.
Jeff Barkas.
Present.
Judy Baum. Melissa Anderson. Neil Williamson. Let me check my chat window here. Is Neil Williamson, were you able to get audio? Nirav Patel. Sorry, not the dog. Philip Johnson. Rodney Reed.
Present.
Sandy Nygaard.
Present.
Sharon McDonough.
Present.
Sean Boker.
Present.
Tara Johnson.
Present.
And Vicki Bennett.
Present.
I counted 16. So we have quorum.
Excellent. Thank you, Shelley. So just a few Google Meet housekeeping items I wanted to make sure that we covered. If you are on the online meeting, if you hover your mouse over the bottom part of the screen, the buttons will appear to turn your video on and off, to unmute and mute yourself, as well as to hang up. Just a reminder for all attendees, these meetings are public meetings, so they are recorded and will be posted to the ADHS website. Anything said verbally, viewed via webcam, or typed into the chat box is recorded and becomes part of that recording, which is posted to the web. Please remember to keep yourself on mute when not speaking. If attending by phone only, press *6 to unmute yourself. Shelley will be displaying materials for the group, so there's no need to present your screen or share your screen. Both Shelley and Julia, and I believe Allison, are all monitoring the chat box for questions as well. And for everyone's benefit, since we are doing this remotely, if you could please identify yourself before stating your remarks, so we can capture who's speaking. We are getting a little bit of background noise, so if we can please make sure everyone is on mute. Thank you. For the attendance report that is attached and in your packet, it looks like we are doing quite well with attendance. I think the online meeting certainly helps that format, so we appreciate everyone being so flexible and working with this online meeting format. In regards to vacancies, we have one vacancy currently. This is for a representative from a federal Indian Health Services organization. Looking at the roster, there are some terms that will be expiring at the end of January. If you are interested in being reappointed or you're seeking to fill a role on the board, you can go to the governor's website. You can also send your CV to Shelley for STAB, and she can send this to Director Chris for consideration. In your meeting packet, we do have the attendance schedule for the 2021 meetings. We have tried to kind of cross-check this against most of the big national conferences, but we always ask that each statutory committee review this schedule and make sure there's no conflicts. So if you could please make sure to just take a quick glance in this and let us know if there's any major conflicts that you see. All right, hearing no conflicts, we will go slightly off agenda here. As I'm sure everyone knows, Terry Mullins will be leaving us as of September 25th. Unfortunately, in COVID times, the best we can do for a send-off is an in-person quick photograph where we stripped our masks off. And so we just wanted to really take some time to really send our thank you to Terry. You know, I think he's been here almost 15 years. Has been a huge component of EMS in Arizona and really working with all the stakeholders across Arizona and the trauma system especially. So we really wanted to just take a minute and recognize Terry for all of his work and wish him luck as he goes back to Montana. So he's going back in time for some snow. I think they've already had snow while we're having record heat. But again, a really big thank you to Terry, and we're going to miss him greatly here at the Bureau. Last opening remarks from me is just regarding our dashboards. We have developed, or I shouldn't say we, but the Bureau of EMS, led by Voxel and her team, had developed several dashboards which are posted on the Bureau's website. These are especially useful for trauma. I think you guys have been able to see the trauma tableau dashboards that are being put together and posted on our website as well. So these are publicly available. If you wanted to drill down to your county and try to pull specific trauma data, those are available. And so we really wanted to make sure that you please take some time and explore that. All right, and I will hand it off to Terry for his Bureau Chief report.
Good morning, everybody. Thank you, Dr. Bradley, and thanks everybody for your nice notes. It's a bittersweet for me to be moving on from Arizona. We've had an opportunity to work together for quite a long time, and I've appreciated all of your patience as we here at the Bureau have worked to provide services to the trauma community. I wanted to just give you a bit of an update for how the department will be conducting the search for the Bureau Chief position. My boss, Jessica Rigler, has asked that the department advertise the position very broadly, both in-state, within the department, in-state, and across several, and with several national organizations. And we have been receiving resumes and applications, and I believe she will try to begin the interview process early next month. And it typically takes something on the order of 45 days to make an offer and onboard someone. So I would anticipate by mid-November there should be a replacement Bureau Chief. In the meantime, Ethan Yanofsky will be the acting Bureau Chief, and any questions that you have, of course, just follow your normal process, working with Noreen and her team. Ethan will lean in, and Dr. Bradley will lean in, and Ben will lean in, and they'll provide whatever service that or any assistance that they can. The other thing I'd like to briefly talk about is the fact that we are in the process of updating Article 9 in our rules. Article 9 is the CON rules, and Shelley's displaying a graphic right now, which is all the ongoing rule making that is taking place. Some of these are related specifically to air ambulance, others ground ambulance, and then some are a mix between ground and air. Article 9, though, I think is of interest to all three of our statutory committees simply because it's the one that deals with certificates of necessity and data collection and quality improvement. And so we have sent out a first draft of the Article 9 rules, and that first draft is based on extensive public comment that we received from our stakeholders last fall and early winter. And the comment period for this goes until October 4th, and then we will have the first virtual public meeting on October 14th from 1 p.m. until 4 p.m. If you have not, by any chance, been on the messaging list, the email list for the rules update and other department, other bureau and department notices, please send Shelley Bissell an email, and she will tell you how to get on the distribution list. We want to make certain that as many people are available and can participate as possible. Because the Rule 9 hearing, public meeting will be virtual, it will be a challenge to allow verbal participation from probably a few hundred participants. And so we are asking folks that can to select a spokesperson from your industry so that we can have a fewer number of people needing to make public voice comments. But there is also an online survey tool to submit written comments, and we encourage everybody to submit written comments. This will be an iterative process. We'll take the comments and have our meeting on October 4th, create a second draft, and that process will continue iteratively through the next several months before we have a final draft. The other thing that I wanted to talk to you about relates to some conversations that I've had with Dr. Bradley and our team here at the Department of Health, and that is a sense that perhaps we have not provided members of the staff with sufficient topics and activities as part of the State Trauma Advisory Board, and that we're not effectively using your time, and which is something that we are very interested in making certain that we do. So we reached out to the other states and have summarized information about what activities they do with their State Trauma Advisory Board. And Shelley, can you present that document? It should also be in your packets and on the agenda for the, yeah, there it is, the agenda that you received. We summarized the activity as follows. This is common across many states, that there is an ACS Committee of Trauma Chair report for each state. Frequently, there's a Stop the Bleed update. Many state trauma advisory reports make room for ongoing trauma research, and then also ask the state trauma, the trauma nurses and the American Trauma Society to do a report. And then for those states that have military bases, they frequently invite them to provide a report. Public health emergency preparedness was called as a common theme that we saw in state trauma advisory boards, as are injury prevention activities, EMS education, and then updates on time-sensitive illness and injury systems. And that only makes sense because, frankly, it was the trauma system of care that kind of has been the model for all of the other time-sensitive illness systems of care. So that's and that's a common theme. We discussed that several states have discussed designation process, analysis, and improvement. Many states discussed the designation review with discussion and votes. They frequently have strategic plan updates, and they have telemedicine work groups. They have a pediatric update, a legislative update, area imbalance, interfacility, medical director reports, and system development reports. We saw that several states have regional trauma data reports that they present at their staff meeting, and then they have rotating trauma data presentation based on their audit filters, regional trauma reports, member roundtable, and then we noticed that several states also discussed information from their opioid data reporting. When I was speaking with Dr. Bradley, we thought it would be appropriate to present this information to you, and I think it's also a discussion and action item later on in the agenda, so that you can kind of assess whether or not these are activities that you all feel the State Trauma Advisory Board should look at including as we go forward. And if there are no questions, I think that'll be the end of my report, Dr. Bradley.
Thank you very much. And for those of you who may not have had time to review that report, if you can maybe take a few minutes during the meeting just to glance through that. We are going to kind of discuss potentially adding some of those items to the agenda later on in our discussion and action items. Next, I'm going to turn it over to Ben Fisher for our services section update.
Morning. I've got a couple things to run through really quickly. Vatsal will present the STAB report as an action item here later this morning, but I do want to let her present some of the data that we have collected related to COVID, cardiac arrests, and deaths. We know this has been kind of interest nationally, and so we have produced some information, and Shelley Vatsal is going to share her screen to show the Tableau dashboard of cardiac arrest data real quickly. Vatsal, are you able to present?
No, Ben, I'm here.
I have some technical difficulties with the Tableau. Is that okay if I present the STEM report and this dashboard together? Because the Tableau is giving me a trouble right now to share the screen.
Let me, I think we'll do the Tableau later, and I will just present it as the PDF, if that's okay.
Yeah, that will be perfectly fine.
Okay.
Yeah, that's practically my Tableau.
Okay, perfect.
Yeah. All right. So what we did over here is, we, as many other states and I think other countries have started observing cardiac arrest cases during the COVID period, and we wanted to do the same using our EMS registry, to replicate, to see if we find the similar kind of findings in Arizona too. So we queried our AZPS registry for 3 years and for the same number of months from January to July of 2018, then 19, and then 2020. And we restricted these after removing some of the calls, cancel calls and everything. We restricted it to 911 call, and then to see the cardiac arrest primary impression came up how many times during these months. As you see in 2018 and 19 in January, let's say the first graph, the number is increasing in 2019 and slight increases there in 2020 also. We saw the similar picture for the February and March. There is slightly increase in number of cardiac arrest cases from year to year, from 18, 19, and 20 in the month of January, February, and March. But then what we saw in April, May, June, and July is, if you see for 2020, number of cardiac arrest cases increased slightly higher, compared to the 2018 and 19. In April, in May, in June, again the gap increased, and in July, really high number compared to the previous 2 years. And then the second graph below it talks about the cardiac arrest percent, and what that means is that the percent of EMS impressions that made up cardiac arrest. So if I to interpret it in 2018, in the month of January, 1.3% of all the EMS incidents were of cardiac arrest. And so if we see again for the January, February, and March, there is 1.3 to 1.4% kind of. But when we went into April, May, June, July, again for 2020, the percent of EMS impressions, like almost 1.6% of EMS impressions were cardiac arrest. And then we wanted also to make sure that, okay, let's see with the population, maybe the population is increasing in 2020, and that's why we are seeing a lot of cardiac arrest cases. So we just wanted to remove the influence of the increase in population. So what you see at the bottom graph is the rate per 100,000. And again, even doing that, we saw increasing number of cardiac arrest cases from the month April, May, June, and July compared to the last 2 years. So that's just the proportion of cardiac arrest cases. And the second graph tells you what was the patient disposition, like, either they were kind of dead or they get transported to the hospital at the field, like EMS disposition, what was that? And I'm gonna focus more on the transported cases because it's one or the other. So transported cases, if we see in, again, if we, like in January, February, and March, it's kind of a similar percent gets transported to the hospital. But then the number started decreasing in 2020 for all of the months like April, May, June, and July. Less and less patients were transported to the hospital compared to 2018 and 2019. Like in July, if we see 34% of the patients were transported to hospital compared to 44% and around 2%, okay, in 2019. So that's what the data says, that less patients are getting transported to the hospital, and there are more cardiac arrest cases during these COVID period into 2020. That's it. I think, Ben, if you want to add anything else to this.
No, thank you. We hope to publish some of this information here soon. Obviously, this is of interest, so we understand that people want to get a copy of it, and we are working to get some of this information published to stakeholders. Thank you, Vatsal. Other couple things. So Gail mentioned we do have additional dashboards on the Bureau website on the DQA page on the left-hand tab. If you scroll down, we've created a new one that's just a data visualization tab. And so we're trying to add all of the dashboards as we get them created. We do have a couple more in the approval process. So hopefully you'll see some more data dashboards shortly. And we always welcome feedback on those. So please let us know if there are things you would like to see, or don't like. Don't tell us if you don't like anything. The trauma registry to AZ Peers linkage is now working. The matching requires an exact match, so the date of birth and patient name have to be an exact match, which I know for the trauma centers and trauma registrars, sometimes that's an issue with EMS data. We're talking about other things we can do to try to improve the matching, but the instructions for how to do that and how to sign up are available from Mary Benkert. So if your trauma registrars are interested in that, please reach out to her. We're pretty excited to have that project done. And then the final item I have is at EMS Council, we're going to talk a little bit more about the Cactus program going forward. I know at these meetings, everyone has been very patient while we have troubleshot some technical issues with the Cactus program on our end, and it's kind of gotten to a point where the reports are no longer timely enough for EMS agencies to implement QA change. So we are evaluating alternatives that we would present in January and then vote on the future of the Cactus program and sort of what that would look like. What I can say definitively is the Bureau is committed to creating a data standard that agencies have to meet. And we want to make that as low work for agencies and personnel as possible and as understandable as possible. But unfortunately, the technical limitations had gotten to the point with the Cactus program where we felt it was becoming more work for agencies and for us than we were able to rapidly implement any sort of QA process. So we'll talk more about that at EMS Council if that's of interest to you. And then I think the very last thing is we have an intern this year who she's an MD, MPH student who is, we just sent out her survey that includes some needs assessment items for the Bureau. And so we're asking EMS agencies to please fill that out. So if you are a base hospital or EMS agency, please encourage them to complete that. We only need one response from an EMS agency, and it only takes about 10 minutes to complete. But that information is only used internally, is non-regulatory, and it helps us sort of decide what we need to do for the future of EMS that is non-COVID related. So please encourage people to fill that out. I think that is all I have, and I will turn it back over to Gail.
Thank you very much, Ben. I saw Amber Rice's question regarding the transport. This is specifically only to cardiac arrest patients only. So this is primary impression cardiac arrest is what the EMS provider selected to get into this data set. We did notice, and I think, trying to surmise what the cause of the change from transport to non-transport could be multifactorial. I think we recognize a lot of patients have not been accessing the 911 system, their primary care, or going to the hospital. So a delay in seeking care can certainly affect our transportation rates. Before we move on to the standing committee reports, any questions regarding any of the Bureau report items? All right, hearing no questions, we will move down to the standing committee reports. First up, Sean Boker for Trauma and EMS Performance Improvement Standing Committee, please.
Good morning. Can everybody hear me?
Yes, thank you.
Okay, excellent. So we talked about at our TEPI meeting, we discussed the discretionary reports and decided that opioids would remain in the first slot, but there was a recommendation for an additional report or additional evaluation, and that was on the safety of COVID guidelines and recommendations. And I think everybody wanted to evaluate what EMS is currently doing with those, how they're using them, and if that's affecting the care of the patient. And so we agreed to add that as a second item in the discretionary reports, and all of the other items were moved down. We reviewed the Cactus data set as well, and we discussed, the purpose of the Cactus data set is a quality improvement to give benchmark data back to EMS agencies. And we have core data elements. Almost all of those are above 90%. A few are below standards, but the total data completion is at 82.2%, I believe. We talked about eliminating some of the data points from the data completeness, but still retain them in the data set. And the rationale for that is because some, like the secondary impression, don't apply to all patients, i.e. chest pain. And it's not a mandatory field, so people struggle to get those filled in. And because it's not consistently completed, it skews total completeness percentages. So there was a proposal to identify elements that we don't expect to have a high percentage be complete. And then we also discussed the premier percent complete requirement that no benchmark has really been approved yet. And so we kind of talked about further recommendations to the EMS Council that we would continuously evaluate these items and determine which ones are indeed impacting completeness and whether or not they need to be continue to be included in the total data completion. And I think that's primarily it for TEPI. Thank you.
Thank you very much. Next up, Sandy for Education Committee.
Thank you. Can you hear me okay?
Yes, we can. Thank you, Sandy.
Thank you. A lot of our time in the Education Committee meeting was spent on reviewing our and amending and doing the updates for our PowerPoint presentations. We worked on sepsis, the training modules for sepsis for Brewery, and chest compressions only PowerPoint. So that was a lot of our time was spent reviewing those. So that was really all I have to report. Very short.
Excellent. Thank you, Sandy. Next up, Franco for PMD.
Microphone check. Can you hear me okay?
Yes, thank you.
Okay, so the PMD Standing Committee met on July 16th. We had a quorum. The main issues were, in the chairman's report, we reviewed the T3Gs, drug profiles, and Table 1, all posted to the website by that time. EMS for Children also gave a report as far as discussion and action items. We approved our minutes. We discussed, amended, and approved the updated Table 5.1 Arizona Scope of Practice for EMCTs with several wording edits and organizational layout changes there. That motion did pass. We discussed adding high-flow nasal cannula to the paramedic scope of practice, but felt that that was covered with more general language regarding positive pressure ventilation devices. And then we discussed the bylaw review and roster roles as well. There was specific discussion about trying to add a toxicology expert to the roster for PMD in addition to the current roster as it stands now.
Excellent. Thank you very much. Next up, Trauma Managers Workgroup, Kara Mitchell. All right, Shelley said she is not sure if Kara is on the line. Is there anyone else that was on the trauma managers work group that would like to give an update? All right, if not, we will move on to the PACES report. Julia?
Good morning. At the PACES meeting in July, we discussed the results of the National EMS Data Analysis Resource Center survey from earlier this year, and that survey will take place again this upcoming year from January to March. So that's a survey of all EMS agencies. We also discussed the National Pediatric Readiness Assessment, which was supposed to take place this year, but will now take place next year. So promotional materials for that will soon be going out to emergency departments. We also discussed and approved the development of a work group for children and youth with special healthcare needs. So we have had one meeting of that work group and hope to accomplish some projects in the future. That's all.
Thank you very much. All right, next we will move on to discussion and action item. First in the agenda, we have
I think Karen Mitchell's on the phone. I don't know if she's having trouble with her audio.
Kara, are you there?
Hi, can you hear me?
We can now.
Can you hear me?
Perfect.
Oh, perfect.
Yes,
Sorry.
That's okay. Thank you.
I apologize. So we are actually planning to meet for the trauma managers on October 25th. And we are actually going to be talking at the trauma managers group about the connection between the registry and Allscripts and how our programs can be better to utilizing that program. So we actually have that on our docket for our October 25th meeting.
Excellent. Thank you very much. Thank you for catching that, Dr. Nortrika. Next, we will move to the discussion and action items. In your packet, we do have the meeting minutes from our last meeting. If I can get a motion to discuss, amend, and approve the staff meeting minutes from May 21st, please.
I make motion.
Sorry, can we get a name with the motion, please?
This is Brent. Forget.
Thank you, Brent. Is there a second?
This is Sandy. I will second them.
Thank you, Sandy. We will scroll through the minutes. If anyone reviewed them ahead of time, are there any amendments that are needed to be made to the minutes? Hearing no amendments, all those in favor, what we may need to do so that we can adequately in this format catch approval. Shelley, do you want to just run through the roster for A's?
For a roll call vote.
Yes, and we can run through just to make sure there's no what people's votes are.
All right, Brent Verbiget, aye to approve the minutes as they stand.
Aye.
David Natrika.
I'm sorry, what was that?
We're doing a roll call vote to approve the minutes as they stand.
Approved.
You can vote. Oh, okay. Debbie Johnston.
Aye.
Franco Castro-Marin.
Aye.
Gail Bradley.
Aye.
Garth Gamer.
Aye. Aye.
Herman Butler.
Aye.
Ayman Fizerfan. I don't hear Ayman. Jeff Farkas.
Aye.
Neil Williamson.
Aye.
Rodney Reed.
Aye.
Sandy Nygaard,
Aye.
Sharon McDonough,
Aye.
Sean Boker,
Aye.
Tara Johnson,
Aye.
Vicki Bennett.
Aye.
Okay. Is there anyone that I did not call your name that's a member that wanted to vote on the minutes? All right. Hearing no nays, the minutes are approved as stands.
Thank you, Shelley. Next, we'll move on to the 2020 annual staff report. If I can get a motion to discuss, amend, and approve the 2020 annual staff report.
So moved, Castro Marin.
Thank you. Can I have a second, please?
Second.
McDonough.
I think that was a second with Sharon McDonough. Is that correct?
That's correct.
Thank you very much. All right, hopefully everyone who is online can see the screen that is presenting. This did go out in your packets as well. So we do have this in here. I want to make a big thank you to Vatsal and her whole team for putting this report together. This is a lot of work annually. It's really important representation of trauma and injury across Arizona. So we really appreciate all the effort that went into this. For those of you who have had time to review this, since it is quite a large report, if there's any specific areas and pages that you'd like to review, we can certainly address those as well. So this is definitely an opportunity for the committee to kind of review the data, give feedback, and provide any thoughts that you'd like to add to this report. One of the things that I did note that was interesting, kind of looking at the trauma incidents and rates, we do see that we've had a steady increase in trauma incidents year after year. I know there was initially thought that some of this was due to the increased number of level 1 trauma centers. However, that number has been fairly stable, and we still continue to see a rise in trauma and injury across Arizona. Vatsal, are you on the line to discuss?
Yes. Yep. Do you want me to start?
Yes, please.
Can we please go to page 6, Shelley? Yeah. So this page describes a summary of the trauma, our annual trauma report. We had total 47 hospitals submitting data for the 2019 year. Of those, 13 were level 1 trauma center. One of them was a pediatric trauma centers. And a total of 58,000 cases, 604, 58,000 cases were reported to the trauma registry. Let's go to page 11. Yeah, this is what Dr. Bradley was talking about, as we see this is the first graph talks about from 2010 to 2019, we have a steady increase in trauma rate over the years. And again, yes, we have increasing in the trauma center, but in last few years, we do not have much increase in the trauma centers, and we still see that steady increase in trauma rate over the years. Figure 2 talks about age and gender specific trauma rate per 100,000. And as we see that all age groups are higher among males, except for the age group 65 plus, where the female have a higher trauma rate compared to, slightly higher trauma rate compared to males. Otherwise, in each of the age groups, males, we see a higher trauma rate. When we look at the race-specific trauma rate, figure 3, can we scroll down a little bit? Down, yeah, yes. American Indian and Alaska Native have the highest trauma rate per 100,000, and followed by whites and then black. Asian and Hispanic had a the lowest trauma rate compared to other ethnicities. And I think this has been the picture since many years now. Okay. Page 12, next page, please. Yeah. This table gives all the mechanisms of injury reported to the trauma registry. So we had total 58,604 cases of trauma, and we see that fall made up 45% of all our trauma cases. Now followed by MBT occupant, another 20%, and then followed by stuck by and against is around 7% of the cases. So yes, almost approximately half of the cases were falls in the trauma registry. The third column shows the deaths, total 1,335 deaths, which is kind of 2.27% mortality. Let's go to next page, table 5. Now in table 5 is the same, exactly same information. It breaks down by the mechanism of injury, but this is only for the severe trauma, which is ISS greater than 15. So there are only 5,873 cases where ISS was greater than 15. So these are more severe cases. And again, in that, fall came out to be the number 1 mechanism of injury, followed by occupant. And then you say instead of struck by against, we see the motorcyclist. So there's a slight change in the order of mechanism of injury, but the fall is like number 1 in both. Let's go to the next page. Slightly below. That's a trauma rate per top 6 mechanism of injury. Can we go to page, is that page 14? Yeah, okay, here. That's gender specific trauma. That's the one, figure 5, sorry. Yeah, figure 5. So what we see over here is a difference in the mechanism of injury by gender. And in female, what we see is that fall 54%, so more than half of the cases were falls, whereas in male, 37% of the cases were falls. Then MBT occupant, almost quarter of the mechanism of injury among female was MBT occupant cases, whereas in male, 16% MBT occupant. But then we see some other, like stuck by against is 9% among male, whereas it's 4% among female. So there's a slight difference in the mechanism of injury by gender. Female mainly falls, more than half, whereas only 37% in male. We'll go to page 15. Now this describes the intent of the injury, this page. So there are unintentional injury, assault, self-harm, and legal or war. So what was the intent of injury? And 88% of our cases were unintentional. And if you see in figure 6, can we, no, down, on the same page, but figure 6, yeah, figure 6, that shows the unintentional injury over the year is the one which is likely increasing over the years. And then the figure 7 talks about, if we scroll down, yeah, gender difference by the intent. What we see in female, slightly higher percent unintentional compared to male. And so among male, assaults are slightly higher compared to female. So that's just describing the intent by gender. Let's go to page 17. So that's trauma mortality. We have been since years, our trauma mortality proportion is in around 2%. And that's what, again, in 2020, we observed 2% mortality rate. And as we see, as the age increases, kind of the mortality proportion increases with the age. Can we go to page 18, please? So trauma mortality, gender-specific trauma mortality, and there's a huge difference between male and female. I think almost male have 2.5 times higher mortality as compared to females. And when we look at the race and ethnicity of whites, Hispanic and Asians have the lowest, but then the white, American, Indian, and Black kind of have similar high mortality compared to, again, Asian and Hispanic. They have the lowest mortality per 100,000. Can we scroll down a bit below? Yes.
Dr. Castro-Marin had a question regarding the trauma rates and mortality.
Sure.
He wanted to know, do we have a table comparing year after year changes in mortality rates?
We can certainly do it. I don't have it right now to show it, but as I say, the year after year, the proportion is kind of very steady. It's in the 2%, but the rate wise, we can certainly do it and, include it.
Excellent, thank you.
Yeah.
Franco, did that answer your question?
Yes, it did. Thanks, Gail.
Okay. What we see in figure 15 is the age-adjusted trauma mortality rate, and we have compared the trauma registry with statewide trauma deaths, and the way we calculated statewide trauma death is from using the death registry database, which is DAVE, database application for vital events. And you see over the last, it's kind of also somewhat answers your question, Dr. Castro-Marin, is year by year you wanted to see the mortality, and obviously this is an age-adjusted mortality, which again, it's very good if we want to do the comparison over the years. So if we see in ASTR from 2017, 18, and 19, there is not much, slight increase in 2019, but 16.1 to 17.1, there's increase in mortality over the year. And I have Dave, I did it over there. It's just to show that we still do not account for all the trauma-related deaths in the state of Arizona in the registry. So that's where we see the difference that, the people who are dying at some other hospital, non-trauma hospitals, or at death or on scene, we are not able to capture this in ASTR. So actual burden of trauma is really higher than what we see in trauma registry. We can definitely get, as other questions, mechanism of injury from Dave, and yes, we can get the mechanism of injury from Dave. I will write it down, make a note of that. Right, we go to trauma charges. Yes. Now this, again, last 3 years of trauma charges, we see, 2.1 billion to 2.6 billion to 3 billion trauma charges. And the median, I don't know what's over there, in 2017 to 18, we made a jump from median 23,000 to 28, but in 2019, the median charges were not very similar to 18. Let's go to page 21. Okay. Drugs and alcohol. So we have overall 13,000 cases, which is 23% of our trauma cases had either suspected or confirmed either drug or alcohol was present. So almost a quarter of the cases of trauma registry cases had either drugs or alcohol suspected or confirmed use was there. When we look at the age-specific proportion, the green is drug and the red is alcohol. And we see that by age group, the younger age group, we can see that the drug is more compared to alcohol. almost like quarter among 18 to 24 and 25 to 44, if we see like, quarter of the patients had either drug or alcohol present in their system or suspected, when involved in trauma. When we look at the race-specific trauma proportions, we see the preference over here, like American Indian, we see more of alcohol, and that's huge, like 42% of the American Indian who were involved in trauma had either suspected or confirmed alcohol. Whereas in African American, we see that drug is more, like 21% compared where only 12% alcohol. Among all other ethnicities like white, Hispanic, and Asians, we see this either drugs or alcohol, it's almost similar. Okay, intent specific. Thank you. Intent specific trauma proportion by alcohol and drug. As expected, if it's an unintentional trauma, we see around only 10% of cases had either drug or alcohol. Assaults, then it jumps. If it's assaults, it's intentional, more likely that you have either a drug or alcohol in your system, and that's what our data shows. Yes, 32 to 38%. Self-harm, the same thing. We are going to see more influence of drug and alcohol. So in unintentional, around 10% the cases. And then the figure 20 shows which mechanism had what proportion of drug and alcohol. And it's going to be again similar. We will see less among falls and MBT occupant because they are unintentional, whereas struck by against cut peers, we are going to see high because they are intentional traumas. Okay. Can we go to page 22, please? Yeah. Page 22, protective device. One before. Yes, 22. This talks about use of protective device in different mechanism of injuries. So MVT occupant, we have that's pretty good. And over the years, I'm observing we are here around 70%, between 70-75% seatbelt use. And that's what it shows year by year. Some of the age groups, middle age groups, those 15 up to 44, we see little lower, but other than that, it's pretty good. Pedal cyclist, as always, we have a very less helmet use among pedal cyclists. And we also see in figure 24, if we go off-road vehicle, we see the similar picture. Can we scroll down a little bit down? Yeah, again, the helmet use among the off-road vehicle occupant, these are basically for recreational vehicles. And we see the similar thing. People are not wearing helmet that much. Motorcyclist, it's around 60% helmet use. Among all the age group, a little bit here and there, the differences. Okay, can we please go to page 23? Access to care. Okay, so this table 18 and 19 talks about access to care, and we basically restricted this table to only the severe trauma patients, injury severity score greater than 15. And these are the patients basically needs to reach to trauma center, as soon as possible. Sorry, my screen got locked. I was not touching the laptop. Just give me a second. Yeah. So what we see is, before I interpret the data, I want to again point it out, injury missing time. We have more than 50% of the cases around 50% of the cases where I didn't have the injury time to calculate this median time. And hence, the data is kind of not reliable. Again, it shows the importance of how valuable this information is and how valuable is that we need to get some of the pre-hospital information. But in that remaining 50% of the cases, what we see is statewide 49 minutes it took, from injury to arrival of the ED for patients with ISS greater than 15. Slightly higher in rural than urban. And what we see in table 19 is that, okay, if you have an in-between halt. So if there's an interfacility transfers, then obviously the transfer patients are going to take a longer time than reaching to their last destination. And it shows in between time at another hospital and then reaching to a definite level of care. So around 326 minutes it took from statewide. But again, I see that I have an injury time missing in a very large proportion of cases. Okay, can we go to page 24, please? This is a regional analysis. And so what we see as every year, we see that northern region, we have higher trauma rate compared to the central and southeastern. Like southeastern has the lowest trauma rate, followed by central, and then the western is little high, and then the northern comes out very high. So figure 26B, we saw like, okay, let's see about the injury severity score greater than 15, and then we again saw the same picture. Northern had a higher trauma rate compared to all other three regions, kind of got very similar when we restricted to only severe cases. But northern we still saw high compared to other regions. So we wanted to back up our data that, okay, are we seeing the same, am I seeing the same picture in the hospital discharge database where it captures each and every injuries? So if you slightly scroll down and we can see table 20. So this year what we did, if you see the last column, so first column, it talks about all trauma patients. So that is our ASTR cases. And then the second column talks about severe trauma patients, again from the trauma registry, but restricted only to ISS greater than 15. And then the last column, what you see over there is injury cases. And when I say injury cases is based because they come from hospital discharge database. Though it's still not, I have a limitation over here, is that the region of injury in our trauma registry is calculated based on the county of injury, whereas hospital discharge database, they do not collect information on the county of injury. So the proxy for that, the best what we could do is the county of residence, and that's what hospital discharge has. So yes, the region definition would be, it differs slightly, but this is the best we have under the circumstances. So based on that, what we found is still the same picture, that northern region and western region, if we see, have a slightly higher injury rate compared to the central and southeastern region. Not as huge of a difference what we see in the trauma registry, but still they have a higher. So like northern region has 8,321 cases per 100,000 compared to central, which is 7,604 injury cases per 100,000. Can we go a little down? Mortality rate, I want to see the figure 27. So now saying that, okay, we do have higher number of cases in northern region and western region. When we look at the mortality and when we look at the injury severity score, mortality by injury severity score, we don't see much change, difference between the region. And I think yes, that's good. Like, you know, we see around, and the mortality rate is anywhere between 16 to 19 among all the 4 regions. Can we go to page 28, please? Right. This is traumatic brain injury. As we see in traumatic brain injury, so the first table of traumatic brain injury is divided into major TBI and minor TBI, and it is based on the CDC definition, and the classification is based on CDC definition using ICD-10 codes. Table 27, which is on the next page, it's basically, or maybe another page. Yeah, table 27. This is based on the Glasgow Coma code using the GCS, the TBI classification. Can we go back to, but I think we see still a similar picture in both the tables. So over here, if we see less than 1 year old and 1 to 4 year old, that's where we see a huge number of proportion incurred TBI. And then elderly, we see after that elderly patients, we are seeing more of a TBI compared to the in-between age groups. And can I see the graph below that? Yeah, and this talks about, okay, which mechanism of injury have a higher proportion of traumatic brain injury. And if you see all kinds of motor vehicle traffic accidents, MVT motorcyclist, MVT pedal cyclist, MVT pedestrian, which totally makes sense. You know, these patients have almost like half of the patients got traumatic brain injury. And we also have like with their child and adult abuse, again, it makes sense, you know, they are more likely to get traumatic brain injury compared to other mechanisms of injury. Let's go to page 30. So this table 28 shows us the admission rate and then the discharge to rehab rate. So if we see total number, there was 33,443 trauma patients out of all the 58,000 we talked about in the beginning. 33,000 got admitted to the hospital. And then when we look at the admission rate by primary payer, then Medicare population, we see 34% got admitted, which kind of again makes sense. Then followed by excess and private has similar distribution, like 30%. Self-pay, only 5% got admitted. And those patients who were admitted, okay, then how many were discharged to rehab? And as we see, Medicare patient has higher rehab proportion compared to other insurance. And then the excess and private, excess is lowest, 5%, and then the private is 8%. So overall, like 8% of patients who got admitted were discharged to rehab. That's what it is saying. And then I divided into, okay, ISS less than 15, then how many are discharging, and ISS greater than 15, then how many were discharging to rehab. And obviously with the more severity score, you will see higher proportion getting discharged to rehab. And then the table 29 talks about the rehab proportion by region. And I mean, it's anywhere between 7 to 10%. Southeastern region is 10%, whereas central region is 7% is discharged to rehab. So that's it. That's the end of STEP report.
All right, thank you very much. So we did get a couple notes. I'll just run through this, the comments that we got that we will definitely look for next year. One was to include year-over-year changes in mortality rates, mechanism of injury from Dave, and look at falls and getting into more details about that. Are there any questions or comments from the group regarding the STAB report? Thank you, Sean. Yes, great work to Vossel and her team. Any other questions or comments about any component of the report?
Gabe, just only one thing I want to say. I saw some of the comments and some of the questions. I didn't have time to go through each of the questions, but we will get back to you guys, you know, once I will work on those questions, and we'll get back to you guys on that.
All right, so my last attempt to try to get everyone's vote was rather ineffective. So I think what we will do this time, we had a motion and a second. We will take a vote. All those in favor that say aye, and then if there's any opposed and say nay. If there's nays, we'll do a roll call vote. So all those in favor of approving the staff report as presented, please say aye.
Aye.
Aye. Aye.
Thank you. Any opposed? Any abstentions? All right, thank you. Staff report is approved. That was much more efficient. Thank you for bearing with me the first time. The next is more of a discussion item. We did want to bring forward just an open avenue to discuss the regulatory impact of COVID-19. We recognize this global pandemic has changed kind of all components of medicine, from certainly pre-hospital and into hospital setting. We wanted to just give the opportunity to this group to bring up any questions or concerns that they may have in regards to COVID and the trauma system. All right, hearing none, we will move on to discuss and approve future STAB project/agenda items. So Terry mentioned the list of activities that we received from other state trauma boards and committees, and I wanted to kind of go through this with this group and just see if any of these reports would be beneficial for us to add to the STAB agenda. Really, our job as the Bureau staff is to kind of help coordinate this meeting, but this meeting is really your meeting to run in terms of what topics you would like covered and discussed. So we really wanted to just bring out some of the discussion pieces and ideas that we got from other components in other states, and really see if we could add some of this to the agenda to make this more beneficial for your time. So for those who've had the time to look at this, of any of these topics that you see, are there any that you would like to see added to our STAB report and discussion items here? A couple that I look at that seem very interesting to me are trauma research and a military report. I think obviously trauma research is how we guide a lot of our care. We've had some pretty amazing trauma-related research that has come out of Arizona, including the EPIC TBI project, as well as the recent SMR paper that was published as well. And I'm sure there's many others. So I would like to suggest that we include a trauma research report to the agenda, unless there's people in the group that disagree with this. We also have a number of military bases. It would be interesting to see if there's any information that would be interesting to report back from military-related work if anyone works with those groups. So those are just kind of, when I look at this, 2 items to consider. Any thoughts on those items? Some other items that were also kind of on the list that we got from other states included things along the lines of telemedicine, pediatric updates, air ambulance committee, looking interfacility transport committee, and potentially developing some subcommittees from STAB. So those would be some other options, as well as a regional trauma update. Is there anyone in this group that works with any of the military installations or military personnel?
This is Debbie Johnston. I believe we've got some of the military installations, and especially if not the installations, also hospitals, VAs, are part of the Healthcare Coalition. This is the one for emergency response, but I can tap into that group and find out what those actual relationships are.
Okay.
Hi, Gail. It's Amber.
Hi, Amber.
Our EMS group works with some of the PJ physicians, the pararescue jumpers at Davis Mountain down here in Tucson. So we have a couple of their PJ medical directors who are part of our EMS faculty group. And work with our EMS fellowship program. So, I mean, we could ask them to, they do research with us and help us out a lot.
Okay, that would be great. So I heard from the 2 things that we may add is a trauma research topic, which would be open to anyone who's doing any type of trauma research that they wanted to present, and then a military report. And it sounds like Debbie and Amber have some connections, and we can potentially get some reports from them. Any other ideas from this list that you guys see? We certainly want to include as much as possible to make this worthwhile for your time.
Hey, Gail, this is Andy Tang from Tucson.
Hey, Andy.
Hey, you know, Nurse Patel is the ACS COT region chair or state chair. And I think that it may be worthwhile to have him kind of discuss the things that are happening on the American College of Surgeons side in terms of trauma care. And I think that coordination between the ACS and the state would be good. You know, there's things like Stop the Bleed, which is one of the agenda you had listed. That's part of the ACS agenda as well. And so things like that can probably be combined.
That sounds great. I think that's an excellent, it sounds like Dr. Patel, you just got volunteered. I saw you did join us in the meeting, so excellent. You may get pulled into that, Andy, but I think that sounds like three additional topics.
Hi, Gail. This is Matthew Nichols.
Hi, how are you doing?
Good. So I'm currently in the Army Reserves. I'm a lieutenant colonel, and I actually work directly for the Office of the Surgeon General of the Army. I'm the Deputy Chief of Disaster Medicine and the Assistant Medical Director for all of Army EMS. When I was active duty, I was at Brooke Army Medical Center, where the Joint Trauma Registry has come from, and basically all the research out of the Institute of Surgical Research for all joint services. So I can reach back and kind of participate in the military side as well.
Excellent. Thank you very much, Matt. All right, so I think it sounds like we've got three great topics to add to the agenda for January. I know Dr. Spates is really excited to give an EPIC TBI update with some of the newer research that's come out with that. So we will have at least one research topic. And it sounds like we've got three connections to cover military. And then between Dr. Patel and Dr. Tang, I think we should be able to get an ACS COT report as well. So.
And Gail, one question in regards to the research component. Are we looking specifically for trauma research that's related to pre-hospital care, or are you looking for reports on research that's just across the whole spectrum?
So really, that's up to this committee to decide. Certainly the State Trauma Advisory Board oversees the trauma system, which includes from pre-hospital care. So I think that's really up to this committee's decision. I think it's exciting just to hear potentially what research is going on that's trauma related in the state. So my thoughts would be to include both, but I would leave that up to this committee to decide.
Okay.
Gail, this is Sandy. Do we think perhaps a legislative committee might be of interest, considering a lot of what we do is tied to the legislature?
Sure. I think the committee development, that's something that's always kind of subject to the Bureau's workload. So I think subcommittees are great. I think that definitely if we have the time and workload capacity, I think the legislative committee is an excellent one to consider. So I would put that as our top, unless someone feels otherwise, as our top committee if we have time. All right. So I think we do have this as an action item because we have discussed and approved future staff projects / agenda items. So if I can get a motion to discuss and approve staff projects and agenda items.
So moved, Sprint Burgett.
Thanks, Brent. Can I get a second?
Second, Sean Bowker.
Thank you, Sean. All right. Right now we have the four topics that we would cover at ACS/COT report, trauma research, military, and a legislative subcommittee. Is there any further discussion regarding that or any other items people would like to add to the list? All right, hearing no further discussion, we will use the same method for approval. All those in favor, please say aye.
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 Any opposed, please say nay. All right, and any abstentions? Thank you, motion has passed. Well, that is quite exciting. I think it's been a while since we've had new topics to the SAB agenda, and so that will be really good to start adding some additional content to this meeting. Last discussion action item is if I can get a motion to discuss, amend, and approve updates to the bylaws, please.
So moved. This is Sean Bowker.
Thank you, Sean. Can I get a second, please?
Second, Brent Burgett.
Thank you, Brent. So the minutes are projected. They are also in your meeting packets. We are tasked with updating our our bylaws every 3 years. So we are due to have these updated by the close of 2020. There is a key at the top. So green highlights and strike through are bureau updates. Yellow highlights is from subcommittee. We did have a work group that met with members from all 3 statutory committees. This went back to Dr. Johnson, who was the chair of that committee. After the bureau had their additions, they did not feel that they needed a second meeting. And so these are the proposed minutes that we are, I keep saying minutes, proposed bylaws that we would like the committee to consider. Are there any amendments or changes that the committee would like? All right, hearing no changes, we're going to do a vote again, same method as the previous vote. All those in favor of approving the updates to the bylaws as presented and in your meeting packet, please say aye.
Aye. Aye.
Any opposed? All right. And any abstentions? Thank you very much. The bylaws have been updated as presented. Next on the agenda is items to be considered for the next meeting. I know we did cover that in some degree, but we wanted to open this up to anyone who had further items they'd like to have consideration for the next meeting. All right, next up, call to the public. All right, attached is a summary of current events. I will not read through these because we recognize that these are changing constantly and many of these are moving remotely. Our next meeting is January 21st, 2021 at 0900. Location to be determined. We will likely continue to have the online format moving forward. Hopefully at some point we can all get together in person once again. I need a motion to adjourn the meeting, please.
So moved, Brent Burgett.
Thank you. Second?
Second, Debbie Johnson.
Thank you very much, Debbie. All right, meeting is adjourned. Thank you everyone for your participation. We really appreciate it.
Thank you.
All right, bye-bye.